Good evening. My name is Lisa Cawthorne. I'm your host for our live webcast called Focusing on You, sponsored by Hope Abounds. Hope Abounds is an organization that helps women and children with cancer and their families through advocacy, financial support, and education. It's very fitting that we're discussing a topic of familial and genetic markers for cancers, as it's Ovarian Cancer Awareness Month this month. And of course, the color is teal, so I'm wearing teal for that. I am also a breast cancer survivor. I'm BRCA2 positive, which our guest will help explain a little more. I also volunteer with Hope Abounds as a patient advocate, and I'm an oncology nurse. So tonight we're thrilled to have Tammy Kimball. She is an account executive with Myriad Genetics, and she is here not so much to represent Myriad, but here is a previvor, which Correct. You're going to talk about a little more.
Correct.
So
Correct.
Tammy, tell me a little bit about your personal story.
My personal story. So, correct, I'm a previvor. So I always say that I'm very humbled and honored to be a previvor. So first, for those that do not know what a previvor is, a previvor is one who's at risk for a disease, illness, cancer, but has not had cancer.
Okay.
So as you said, I'm BRCA1 positive, but I've never had cancer. My three older sisters are BRCA1 positive, and all three of them are in remission from breast cancer. So they are survivors, and I am a previvor. So really the goal is to find more previvors like me and really prevent cancer.
So how did that process come about? Were they diagnosed and then did the genetic testing, or sort of what is the history that happened in your family
Right.
that caused a sequence of events to
Right.
go for genetic testing?
So in our family, I have 4 sisters, so there's 5 girls, no boys. So poor dad, sorry. All these girls. In 1994, my sister Cynthia was diagnosed with breast cancer. And in the mid-90s, Myriad actually discovered these BRCA genes, right? That was the discovery of all these of BRCA genes. Cynthia was diagnosed with breast cancer in 1994. She went into remission, and we thought, that's it. And by the way, she was 31 years old.
Young.
So young cancer. Remember that, young cancer. Thought it was a fluke. Then my sister Christy was diagnosed with breast cancer a few years later, age 33.
Young.
Young cancer, multiple, same side of the family, remission. And then the oldest sister was diagnosed with breast cancer, 39.
Still very young.
Still young. Still very young. They shared the same oncologist. So they were all diagnosed. It was still, early 2000s when all 3 of them were diagnosed. And so he recommended genetic testing. So the genetic testing came back positive, BRCA1. So what he recommended is that my younger sister and I get tested as well. So my younger sister was tested, and she came back positive.
And how old was she at the time?
Jennifer
remember?
was in her mid-30s, early mid-30s.
Okay.
And then in 2004, I still had not been tested. I was the last Kimball sister to get tested. And in spring of 2004, I went in for my mammogram. And something came back suspicious. And I went in to see Dr. Gregory Bebb for a biopsy.
Local fella here in
Very
Wilmington.
local fella. And started our long-term relationship. And he said, it's probably not cancer. And I said, well, let's not say that. We don't have a good history in our family.
Mm-hmm.
And it came back, and it was negative. And during this whole time, I didn't say anything to my family, because one by one, everyone was being diagnosed with cancer.
Mm-hmm. Mm-hmm.
Well, when the biopsy came back negative, I thought, well, I'm not positive. This is skipped me, right? All my sisters had cancer. I didn't have cancer.
Mm-hmm.
And then I put off testing a little bit.
Ah.
And my
Because
mom,
you had the safety of having the mammogram.
I had the mammogram. My biopsy was negative. And my mom kept calling me every day and saying, you need to get your testing done. You need to get your testing done.
Okay.
So in October 2004, I had my testing done, and it came back positive. And so I knew my chances, breast cancer. Saw my 3 older sisters go through breast cancer, up to 90%. Ovarian cancer, chances up to 63%.
For BRCA1.
Right.
Right.
So I have 2 small kids. Number 1, my job is always a mom.
Mm-hmm.
My number 1 priority. Cancer can take such a toll on the individual, the family. A diagnosis of cancer is devastating. A diagnosis that you have a genetic mutation, anxious. So here was the deal with my sisters, the difference between their treatment plan and my treatment plan. When they were diagnosed with cancer, they didn't have control.
You had a path set out for you, whether it's
Now
surgery, radiation, chemotherapy.
Now I had a path. They did not.
Okay.
And I always say they were my guardian angels.
Mm-hmm.
So I was able to sit down with Dr. Bebb and create my timeline. What do I want to do with this information? When do I want to have my surgery? What type of surgery do I want to have? I get to pick and choose my doctors, my plastic surgeon.
Mm-hmm.
My sisters never had that option. And then I was able to sit down with my gynecologist, Dr. Chase, and decide my BSO, removal of ovaries and tubes.
Bilateral salpingo-oophorectomy.
Correct.
I always say it sounds like Mary Poppins said it. So
It-
everyone calls it a BSO, removal of ovaries and tubes.
It does.
Mm-hmm.
And that was a big one for me, too, because that was sending me into immediate menopause.
Menopause, that's right.
Um,
And you'd already made the decision to not have any more children at that time. I'm
Exactly.
assuming.
So
Okay.
I was older, and at that time I was mid-40s. I was not having any more children. That's a real scary cancer.
Mm-hmm.
But again, I had that option,
Mm-hmm.
that roadmap. I was able to sit down with my doctors in a comfortable setting and make that treatment plan.
Mm-hmm.
And by the way, we inherited this genetic mutation from our dad. So my paternal grandmother passed away at the age of 48. And when she passed away, she left behind 8 children. So there again, young cancer.
Right. Right.
Young cancer.
So that's interesting that you mention your father,
Mm-hmm.
because I think the misinformation sometimes is that only women can carry these genes and only women are at risk.
Correct.
So this was passed down from your father. And
Right.
the good news is I think you told me your sisters are all doing well.
They're all doing very well. They're all in remission. They're doing very, very well. And anybody with a genetic mutation, once they've had cancer, and this is what's very important to know if you do have cancer. And I really want to anyone who has cancer, breast cancer, especially ovarian cancer, triple negative breast cancer, colon cancers, rule out a genetic mutation.
Mm-hmm.
For one, breast cancer, ovarian cancer, there's certain chemotherapies that target these cancers.
Mm-hmm.
Rule it out. And then if it's a genetic mutation, there's a big chance that you're at risk for another cancer. BRCA1, breast cancer, ovarian cancer. If it's in my family history, pancreatic cancer.
Right.
Men, prostate cancer. So it's being aware of your family cancer history.
Mm-hmm.
My sisters had full hysterectomies. So it's really knowing your family cancer history. Because my sisters knew they had a genetic mutation, they had the hysterectomy, so they were able to prevent, the ovarian cancers.
Right. And things have really progressed since the 90s also.
Mm-hmm.
It used to be you were diagnosed, you went through treatment, and the genetic testing took so long that it may have taken 2 or 3 months to come back. Now what happens is if someone is diagnosed and they previously haven't had genetic testing, that may even become part of the treatment plan. They may wait to get the genetic testing to decide, should I have lumpectomy, should I have bilateral mastectomy, things like that.
Right.
Isn't that correct?
Right. The turnaround time is fairly quick
Mm-hmm.
with the genetic testing. Oftentimes it's less than 2 weeks. It should be less than 2 weeks for the
That's
turnaround
awesome.
time. With the results.
Mm-hmm.
Sometimes it's quicker than that.
Mm-hmm.
We now do advancements in science, and I always say this to my kids, I love science. Myriad does a 28 gene panel. So that's really important. So advancements in science. So mid-90s, BRCA1 and 2.
Mm-hmm.
Myriad now does a MyRisk genetic gene panel of 28 genes. So it's not just hereditary breast and ovarian cancer that we look at. We look at an array of 8 different cancers. We also look at Lynch syndrome, which is colon cancers, stomach cancers.
Endometrial, I think, is included in that.
Exactly. Endometrial cancer, melanoma, prostate cancer, pancreatic cancer. So there's an array of different cancers. There's a spectrum of different cancers that we look at with these hereditary cancers. There's certain red flags that we look at. We mentioned the young cancers under the age of 50.
Right.
We look at multiple cancers on either side of the family, mom's or dad's side, those multiple cancers, and rare cancers. Ovarian cancer is considered rare.
Mm-hmm.
But going back to our family, so, you see those red flags. We had those young cancers.
Mm-hmm.
My paternal grandmother, breast cancer, age 48. When we look back at our family cancer history.
And she was premenopausal, which
exactly
is considered more of a young breast cancer.
Exactly.
Mm-hmm.
We actually had ovarian cancers on my dad's side. My 3 older sisters, multiple cancers and young cancers. So
I think that challenge sometimes is going further back in the family history.
Mm-hmm.
I was telling someone that my grandfather, for instance, they said, he died of liver cancer.
Right.
When actually he had prostate cancer that had spread to his liver. So
Right.
sometimes that discovery process, you're trying to contact cousins and aunts and uncles and great aunts and uncles and figuring that all out. And I remember having to do a family tree, and it took me a while to
Right.
get all that information, because you may know your mom and your dad, but past that, they really want extended family. So
Right.
how would somebody go about figuring, we've said, young or multiple people or several cancers. How would someone figure out if they're at risk? Is there some way to do that before actually going to a doctor? Like, could they look at something online or?
Good question. So actually, if you go to hopeabounds.org, there's a hereditary quiz that you can take at hopeabounds.org. Takes less than 30 seconds. Answering a few simple questions on that hereditary quiz will let you know whether or not you're at risk for hereditary cancer. And that, if you result positive that you're at risk, it actually takes you to the Myriad Genetics website.
Awesome.
Mm-hmm.
So, it's interesting. I heard someone say one time, they said, oh, all cancer is genetic because of mutations with the cell, but hereditary genetic means it's passed down through a parent, or familial genetic. You may have a strong family history, but we haven't quite figured out if there's some sort of gene mutation or not.
Right.
So could you address that a little?
Right. So if you look at cancer within like 3 buckets. Mm-hmm. You have sporadic, mm-hmm. which if you live old enough, you're probably going to get cancer.
Or heart disease, I always say.
Or heart something. If you live
mm-hmm.
to your 100, probably going to get cancer. Environmental something.
Your immune system breaks down. We're not really sure.
Right, right. Mm-hmm. Familial. There's cancer in your family, but we haven't figured out. That's another mm-hmm. bucket. Hereditary cancers. We know that there's a genetic link. There's a component to that. Mm-hmm. We know that. And the chance of inheriting that genetic mutation is 50-50. It's like flipping a coin. So my dad passing that genetic mutation down mm-hmm. to us was 50-50. We just happened to have some bad luck, right? That all 5 girls. So you actually get a BRCA from each parent. Mm-hmm. We just started off with 1 broken gene. Does that make sense?
Yes. Yes.
So we just, and some people will say, well, it skips a generation. It can't skip a generation.
There are some sort of genetic mutations where you might be a carrier, but then you don't pass it along. Right. But this particular genetic mutation, right. If a parent has it, they have the genetic mutation, correct. Then each child has a 50-50 chance correct. Of inheriting it. And if you don't inherit it, then it stops there.
It stops there. If you don't inherit it, you're a true negative. You are a true negative. And my dad is 78. Mm-hmm. He's never had cancer.
Wow.
But he still is under surveillance.
For,
so he still has mammograms.
Interesting.
And
okay.
He's still at very high risk for prostate cancer.
So they watch him more carefully, mm-hmm. probably with a PSA.
Right.
And this.
Correct.
Mm-hmm.
And I've had people ask me, so when do you stop, at what age do you stop screening or somebody who might be at risk for cancer? Mm-hmm. And my question is, you never stop. I don't care if somebody is 80 years old. I was having a conversation with a physician because that 80-year-old still could get cancer and you would want to prevent it. And that 80-year-old has family. Mm-hmm. So that could be the gift that person could leave to their family, to their children, to their grandchildren, to their great-grandchildren.
Right.
You should always continue to screen and identify patients.
That's right.
It's always interesting, but...
So, if you don't mind sharing, you told me you have 2 adult children?
I do.
And what has happened in their lives and their journeys, knowing that they had this strong cancer history, knowing you carried a genetic mutation. Tell me about sort of the decision process and the emotions and the knowledge base maybe that went into all of that.
So both of my children, they were born in 92 and 93. And as you recall, my sister Cynthia was diagnosed with cancer in 1994. So they've pretty much grown up with cancer. And when I went through my surgery in 2005, my prophylactic mastectomy, I think they really thought I had breast cancer because they didn't know any better.
Right.
And it was only when they saw that my hair didn't fall out that I didn't have cancer. And that's a big thing, that I was okay, that I wasn't sick. And then they started to get the whole proactive and preventative. And I remember my daughter asking, well, what about me?
That's tough, isn't it?
It's tough, but as a mom, I felt very good and relieved and secure in genetic testing for my daughter that it was going to protect her. That if she came back positive, it might be a little bit anxious, but it was a whole lot better than the devastating diagnosis of cancer. Because that test, as a mom, for both of my children, is going to protect my children. So the difference, when I was tested, I was older. So when my daughter was tested, she was 21.
Okay.
She's younger. So my daughter at a young age, her surveillance, I had my roadmap, my treatment plan, but it was older.
You'd already had children.
I had already had children.
And
so,
you also knew the ages of your sisters when they were diagnosed, which probably went into the treatment
And I had
plan.
already gone in and I had one biopsy. So I was, already pretty nervous. So my daughter, her surveillance is including MRIs. And then it also includes, she's on birth control to protect against her ovarian cancer. So
breast MRIs.
Breast MRIs,
right.
Correct.
And birth control pills for ovarian.
To protect against right. So
and did they ever mention transvaginal ultrasound, which is not really that helpful in diagnosis, but sometimes they do that in surveillance. Have they ever done anything like that or recommended
it?
Right.
Right. And I was getting ready to mention that. So she does have transvaginal ultrasounds. Mammograms at this point because she's young and her breast tissue is dense. Right. She has her roadmap. So the birth control is protecting her from ovarian cancer. That protection rate is 60%. That's huge.
That is huge.
The surveillance with the breast cancer is so good. So many people, that's such a misnomer with the birth control and the breast. But it's so important for her to be on that to protect against ovarian cancer. And a lot of times I hear women say, and it makes me cringe, that if you're positive, it means you need to have your breast cut off and your body parts taken out. It's so barbaric and it's so untrue. One, the plastic surgeons in town are simply amazing. They do a great job. And two, you don't have to have all of your parts taken out. And I also had a conversation with a physician, and we touched on this earlier. Doctors see patients every day. And patients come in and they have a background of something. Heart disease, diabetes, cancer. some things. If a patient doesn't come in and they don't have a family cancer history of something, my golly, I want to meet that person because they were living in a bubble. Ours was cancer. Cancer was in my family cancer history. And we figured out that mystery. So I'm BRCA1 positive. So my chance of getting ovarian cancer is 0 because I do not have my ovaries. My chances of getting breast cancer is down to the general population, 4 to 5%. So I always tell people, in front of you, I'm one of the most healthiest people. Cardiovascular-wise, I'm great. My sugar levels, everything's wonderful. So we found that one thing, and we fixed it.
So knowledge is power
Knowledge
in this
is power.
case.
Right, knowledge is power.
And it can be choices.
Right.
Like you said, everybody thinks of Angelina Jolie. She's the famous person whose mother died of ovarian cancer, and she nominated to have bilateral mastectomy, and then she had her ovaries removed after her children were born. So, but what you're telling us is it's not necessarily that drastic step. It depends on what age you are, the risk factors, what's going on in your life. For your daughter, it's more intense surveillance than the general population.
Correct.
Most people don't start mammograms or MRIs or ultrasounds in their 40s maybe, but in her case, they're already looking at her.
Right. So she's being watched. She's under surveillance. She's healthy. It's not stopping her from doing anything. She just got married. She climbed Mount Kilimanjaro. She's a terrific artist. She's backpacked through Europe. It's not stopping her in her tracks. She's a patient advocate speaker. I don't want people to fear getting tested. There's no fear in getting tested. There's fear of being diagnosed with cancer, but there should not be a fear in getting tested. My son was recently tested, and he came back positive. And he's on his roadmap too. I'm proud to say he's a patient of Dr. Bebb's as well. Love that man, super guy, but he's doing well. I mean, he's at higher risk for prostate cancer at a young age. So with both my kids as their mother, this test is wonderful because it's preventing them, hopefully, from getting cancer.
Like you said, if you knew you were going to get heart disease, for instance, if there was a test for that early on, then you might live your life a little differently, or you might have certain tests that you're doing earlier. But we don't really know that yet. So
the only thing I want to say about my son and getting tested is, for a male, it's really hard for men to get tested. And this is why. For women, when they see their gynecologist on if they're new, or their annual exams, they fill out a questionnaire. Most of the time, if they're going to a really good gynecologist and they have a really good family history questionnaire, cancer questionnaire, and that gynecologist, after they fill out that questionnaire, it'll state whether or not they're at high risk and they need testing. So sometimes those women, they're caught at the gynecologist or the surgeon's office or the oncologist. They have cancer. Sometimes gastroenterology, GIs, colon cancer. But the men I worry about, because where are the men being tested and where are the men being screened and identified? They're not. And where are the men going to be tested? There are not enough family practice doctors, primary care, internal medicine doctors testing men. And that's a problem. My son getting tested, we had to find a primary care doctor. Now, I could take him to plenty of gynecologists to be tested, but he really didn't want to do that. And I understand. But as his mother, it was important for me to have him tested. Now, we did find a primary care doctor, and he did get tested. And there are some primary care doctors here in Wilmington that will test men. But there need to be more primary care internal medicine family doctors who do testing, that do screening and do identification. And some have said it's not in their wheelhouse. And this is what I want to tell patients. You have to be your advocate, and you have to fight. And you have to have a doctor who's willing to fight for you. And if you don't have that doctor, then maybe you need to find another doctor. Because this is real, and this is something that your physician should be doing. And when I had my son and we were trying to find somebody to test him, this is what I was thinking about. And I think about all the men out there who are missed, and I think about all the patients out there who are missed, who only go to a primary care, maybe not to the gynecologist.
Right. Now, in some areas, there are genetic counselors that men and women could go to. Normally, they're bigger cancer centers that may have a genetic counselor there, which can be crucial as far as doing some education before the testing and education after.
Such an ideal situation. And I love that situation. And even if the primary care, the GI, if they can screen and identify that patient and refer to a genetic counselor, that's awesome. But they need to be able to screen and identify that patient and refer out. And they need to get educated. And I'm not sure they're doing that. But if they are, thumbs up. Thumbs up to that. And I hope they are. Because that would be the ideal situation. That's what we want. We want these physicians to screen and identify and refer to a genetic counselor.
And going back to your son, we hear a lot about women and breast cancer.
Correct.
What's unusual is men comprise 1 to 2% of the breast cancer statistics. But there's probably some stigma associated with that. Maybe people haven't heard of it. It's hard for men to sort of find that support. With my father, he was diagnosed with ductal carcinoma in situ, or stage 0, we used to call it, breast cancer. And he had a very detailed surgeon who thought he had maybe an infection at first, and he kept chasing it until he figured out that he did have abnormal cells in there. So, and my father had a mastectomy. So it was interesting a couple of years later when I was diagnosed and I had small children and they wanted to know, well, Mommy, what's it going to look like once you have surgery? My dad lifted up his shirt and told him, and I said, it'll kind of look like this scar. But I think the risk for men is only, what is it, about 10 to 20% higher for male breast cancer if you have the gene mutation. I'm not quite sure of the statistics.
Right, so it's a little bit, higher for men if they have the genetic mutation. So if there's any male breast cancer in your family, and this is something that some people don't know, you meet criteria for testing right away.
That's good to know for folks.
So there's some people that meet criteria for testing right away, and that's one of them. Any male breast cancer in your family, you meet criteria for testing right away. So if you don't have cancer, but there's a first or second degree relative, grandparent, uncle, brother, you meet criteria for testing with that male breast cancer in your family. If you're male or female and you have a first or second degree relative with ovarian cancer, you meet criteria for testing. Very important to know. Anybody with male or female with a breast cancer at the age of 45 or younger, you meet criteria for testing.
Mm-hmm.
Some people don't know that those ovarian cancers are just so strong. Those male breast cancers, the stigma, like you said,
Mm-hmm.
can be associated with it. But it's really important to know those factors. Speaking with some people at the imaging center, they have the male breast cancers that come through, and those men need to be tested right away.
Mm-hmm. Mm-hmm. And so what sort of follow-up will your son be receiving now?
So it's early, and I'm probably a little proactive.
Mm-hmm.
He's not supposed to start his, clinical breast exams until 35, but he's started them already. He's 24.
And a clinical breast exam is when the physician is examining you.
Right.
And he should also be aware of any
He
changes.
is.
Okay.
He's very aware, but because of the breast cancer started younger in our family, I wanted to make sure that he went in. So he's going in on an annual basis, so he's starting earlier. But that's just in our family, with a mom
Right.
who's just probably a little bit overly cautious. But and then because he's at higher risk for prostate, so he will start that surveillance at the age of 45
Okay.
with the PSAs and.
Yeah. So you did mention something that I want to bring up. You talked about qualifying for genetic testing.
Mm-hmm.
Is this an out-of-pocket expense for folks, or does insurance cover it? Are there some insurance companies that don't? And I've also heard from people, I don't want to get genetic testing because that will go on my medical record and there might be discrimination. Can you address some of those concerns?
First, there's no discrimination with regards to genetic testing. There's been legal laws that have been passed with regards to that. Insurance is preventative. It's covered on 97% of insurance companies. And because it's preventative, most patients pay zero for their genetic testing. That's what we're finding in southeastern North Carolina, that the majority of patients pay zero out of pocket.
Okay.
With their genetic test because it's a preventable test. Patients, we do have, Medicaid does not cover genetic testing, but Myriad has programs for patients who have Medicaid, and then patients who have Medicare. Unfortunately, Medicare does not cover the patient who is unaffected, meaning the patient who does not have cancer.
Okay. But a Medicare patient is typically 65 years or older.
Right. So, but a Medicare patient who's had cancer, it covers 100%.
Okay. Okay. And so if somebody was concerned and maybe they had Medicaid and they went to their doctor and their doctor said, well, your insurance, Medicaid does not cover it.
We have a program.
What's the process then?
So what they would do, and it's right on our test request form, and any patient go to Myriad, and actually I think it's on hopeabounds.org as well. On the Hope Abounds website, the Myriad Financial Assistance Program is on the Hope Abounds website. So it's right on the test request form. We make it very simple. Right when the patient signs On the test request form, they fill out their annual income and number of dependents. We make it really easy. We do all the prior authorization for all the insurances. We handle the Medicaid. It's very, very easy process for Medicaid, for all the financial assistance. I think a family of 4 for financial assistance is $72,900,
Okay.
72,000, about $73,000 a year. So very, you know, really good financial assistance program.
So one thing we touched on a little bit is your children were in their 20s when they were tested. I've heard some people say, well, why wouldn't you get your kids tested when they're 14 or 15?
Right.
I want to know. Like, I want to know about my children. But the recommendations I've seen typically say to wait until they're in their 20s. Could you address that a little bit?
We typically say 18 and older, and then maturity. I want to make sure that the patient can handle the information.
Okay.
And then what would you do with that information once you have it?
What would you do? Right.
So we've had situation where parents do want their kids tested, but what are you going to do with that information? My daughter, she was tested at 21, 10 years prior to the youngest cancer. But I also wanted to make sure she could handle that information. She was in college. I didn't want to have her tested at the age of 18. She was going to college. She was younger. She was a freshman in college at 18. I wanted her to go to school, enjoy some years. I probably could have waited until she was out of college. But you really want to make sure that individual can handle that information emotionally.
Right.
And like I said, we recommend 18 and older. And once they get those results, like I said, even the medical management with my daughter, with her annual breast exams and MRIs.
Right.
The medical management, what are you going to do with that information?
Right. It does happen, but it's extremely rare that someone would get breast cancer in their 20s.
Correct.
Extremely rare. So to go to sort of those more extreme cases of prevention
Right.
in your 20s would typically not be an option. So,
Correct.
Right.
And that's why we say 10 years prior to the youngest cancer. And typically that's your safeguard.
Right.
So with my sister Cynthia being diagnosed at the age of 31.
And she was the youngest, right?
She was the youngest.
The rest were a little later.
Right. And so that's why we picked 21 for my daughter to be tested. So that's when she was tested, and then, she's on her surveillance. Because, correct, my thinking was I wanted her tested at 21 because you do hear of those cases of young women being diagnosed not only with breast cancer, but ovarian cancer at young ages. And you want to make sure, or at least I wanted to make sure, that my daughter, because you hear of those cases, that she was protected and she was under surveillance.
You seem to go about it in a very sort of analytical and logical and I would say self-empowering approach. Did you have moments where you were emotional about all that happened or not? Or did your children ever talk about that? Because I'm always interested in sort of the approach to educate and talk to your children and talk to other relatives about that.
I think it's really important to educate the community and educate them about testing and not to fear testing, because many people have cancer in their family and many people fear testing, or they think it's just going to happen to me. It's a matter of time. It's in my family. There's nothing I can do about it. or the different reasons. It's going to cost a lot of money. I can't afford it. It's not 97% of plans. Majority of people pay zero out of pocket. I think the average co-payment is $50. If somebody can't afford it, Myriad will work with you. We have great financial assistance programs. We've never taken anybody to collections. Nobody. There's all these reasons that people don't get tested. And I can never figure out why. If you could prevent cancer, why wouldn't you prevent cancer? If you have all this worry on your shoulder, oh, I know I'm going to get it. I knew a lady that said, I know I'm going to get it. I know I'm going to get cancer. I think there was a genetic mutation in her family. She came back negative. She had all this worry, and finally she went tested. She came back negative. True negative, no cancer.
So in that case, she had some relief of her anxiety.
A lot of relief.
Right. And I think it's important to tell folks, too, that just because there may be cancer in your family doesn't mean it's some sort of cancer that could be passed down through genetics that we know about now.
Right. So we also have, Mary does a great job. So we just don't look at genetic mutations. We have what's called high-risk negatives. So that's where somebody doesn't come back positive, but there's still cancer going on in their family. That's that familial. And maybe we haven't discovered a genetic mutation.
Right.
Remember I said mid-90s BRCA1 and 2, and now we're at a 28 gene panel. We've discovered more genes for breast cancer. There's more than 2. So we have these high-risk negatives. So what we do with Myriad is we send a medical management tool back to the physician with the results. Those high-risk negatives, we do some calculations, we do risk models. And if patients are 20% or greater on certain risk models, we include a medical management tool. And in that medical management tool, it's a similar surveillance model of clinical breast exams twice a year, an MRI and a mammogram within that year's time frame. So we do surveillance on those patients, that familial bucket, that high-risk negative. And now we're even looking at, and we're the only lab doing this, we're looking at SNPs or markers in the blood. So that might be that patient that didn't come back with a genetic mutation, or who might have tested way back when for the BRCA genes and came back negative, and then might have had update testing and still came back negative. Now we're looking at different markers in the blood. That might explain the mystery to some of those patients. Advancements in science, it's awesome. So we're looking at different things. A lot of clinical science stuff is going into our test. So now when we deliver those results to the physician and the patient gets a copy too, it's very clearly defined. It's a great medical management tool. The physician gets a copy, the patient gets a copy, and at the end of the report is a phone number to Myriad. So if the patient has any questions about the report, their medical management, they can call Myriad, and they can ask to speak to a genetic counselor. We have over 80 certified genetic counselors at our home office.
So that's another option for someone that may not be able to do a one-on-one session with a genetic counselor. They can at least speak to someone on the phone.
Right. So the patient always has the option to call back and speak to the physician, or if they would like to speak with a genetic counselor, a certified genetic counselor, they can call Myriad's home office, and Myriad can pull up the results, and they can speak with the patient.
And sort of the medical managed advice, I'm assuming, is pulled from like the NCCN guidelines where they look at management of someone that has a genetic mutation. And
Absolutely.
so a team of scientists have all collaborated and looked at the research and figured out this is the best way to do that.
We have a team of 30 PhD scientists that look at all the results, every result on hand. We run the results through a second time.
I so appreciate you being here today. I think it's important for people to know that it doesn't have to be a fearful experience, can be an empowering experience. We've touched on a lot of breasts, a little bit of ovarian. Next week, we're going to have a counselor, a genetic counselor, come and talk to us. And her name is Nira Johnson, and also another breast cancer survivor that carries the BRCA gene, Kim Wellens. But I really appreciate you talking to everyone and sharing your story. As you say, education is power. And the more you talk to folks, and probably your son and your daughter too,
Right.
it really lets people know that they have some control
Right.
over their destiny.
Well, absolutely. Thank you so much for having me.
All right,
I
thank
appreciate
you.
it. Thanks.
Thank you. So I want to tell you to please join us on the fourth Tuesday. Like I said, Nira Johnson will be here along with Kim Wellens, and we will delve into the subject a little more. And I thank you for being here, and it will also be recorded, and you can find it on the Hope Abounds website, the Hope Abounds app, or on Roku. Thank you very much, and have a good evening.